again centralizing. Now this air bubble goes in. Now for initial 8 minutes, we raise the pressure of the eye to like 60 millimeters of mercury, so that there is a stronger adhesion between the tissue and the stroma. And after that, we release a bit of air from the anterior chamber to prevent pupil glaucoma afterwards. So after this, what happens to the patient? Now, as it is only the air bubble which is holding the tissue in place, so patient has to lie flat. So this flat position is supposed to be maintained, especially for initial 24 hours, but first 8 hours are very critical. So during 8 hours, we actually restrict the patient's movement. We say that you have to lie flat. So even going to washroom or sitting up for eating is not permitted. After that, you can give some leverage after your slit lamp examination. If you think that the tissue has adhered well, then you can permit the patient for unlimited mobility.
Do you take any air out anytime?
Just at the operation theatre, we after first 8 minutes we take a bit of air out, but afterwards on slit lamp we don't do that.
How much do you take it out? Because the increased pressure causes the damage as well.
Yeah.
Because we normally take it out as well.
Yeah.
So just asking after how long you take it out?
After 8 minutes. So initial 8 minutes the pressure would be at 60 millimeters of mercury, and then we'll release a bit of air and check the pressure manually, like we do after cataract surgery. So the moment I'm satisfied that the eye is soft enough, then I'll leave. But one precaution is that air bubble should be big enough to cross the borders of the tissue. If it is smaller and any border of the tissue is exposed, then the fluid will get some access to detach the tissue. So initially at operation theatre, this is probably the dimension of.
There must be some training here. You don't do any venting.
We don't do?
Any venting?
No.
No. Yeah. So that's what
we don't do. But there are surgeons who do it.
Yeah. Because in the books and the literature is about the venting. But nowadays we don't do anything.
We don't do it. What we do is a gentle milking movement. So we actually try to express any fluid which is there in between at the interface. So with a gentle milking movement, you actually wipe all those waves of the fluid away. So that is one thing we do. Now this is our data, last 1.5 years, starting from August 21. So we have done almost 40 DACs and 44 DMAC. This has now reached 50 and 17 DSAC. So we are more fond of doing DMAC. What is the reason? The reason is that in DSAC, no matter how clean the surgery is, but the stroma has been cut at some level, either manually or with a mechanical plate. So this is not an anatomical plane. So whenever you cut the tissues against the anatomical plane, there has to be some inflammation. So this inflammation produces some interface haze. So that's why it's my personal experience as well, and this is supported by evidence, that the visual quality after DSAC is always slightly inferior to what you achieve after DMAC. So that's why we are more in favor of DMAC. But there are definitive indications for DSAC even in modern days. This is Turkey, picture taken by me. Out of this side. 3. So if there are any questions, you can stop me anywhere, because this is kind of an interactive session, so you can stop me anywhere. This is my department in Pindi. Alright, so if you look at two OCTs, this is DSAC. So we can see that this is patient's own cornea and this is the transplanted tissue. We can clearly see a demarcation line between the two. And this was the thing I was talking about. This produces a bit of haze. A second problem, if you notice carefully, the tissue is thicker at periphery and thinner in the center. So this is kind of a minus lens which you have implanted into patient's eye. So what do we expect? We expect kind of a hyperopic shift, and that is there. So +1 to 1.5 hyperopic shift, especially if you are doing a triple procedure, you are doing a phaco along with a DSAC, then please do this adjustment for the lens calculation. So +1 to 1.5. But as I was talking for ultra thin DSACs, this is now managed, because the thinner the tissue, the lesser the effect. Now this is DMAC. We can hardly detect that something has been done to the cornea. So this endothelium has been transplanted, but it appears just like a normal cornea. So why not DSAC? Suboptimal visual acuity, slower visual rehabilitation, and induced hyperopia. We discussed all that. And then tissue preparation, obviously, if you are preparing it yourself, then you need to invest. You need to buy the Moria's equipment. And why to go for DMAC? Because it surprises you. The visual acuity which you gain after DMAC will surprise the surgeon as well. The patients, they are 6'9", 6'6", like that. And it gives you a quicker recovery. And then inexpensive equipment. Even you can do, with slight modification of your cataract set, you can do a DMAC. And then utilization of the stroma for that. Because the stroma which is left after preparing DMAC can well be utilized for doing a DAC. And then very low chances of rejection. Assalamualaikum sir. Nazar is here, he is my teacher, Ramir is my teacher. But there are challenges with DMAC as well. It is difficult to learn. It's a kind of a difficult surgery procedure. Then a reliable harvesting of the tissue is a challenge because it is such a thin tissue, as you mentioned, that this is 20 to 30 micrometers. So when you are peeling it off, because you have to peel it off manually, the moment you are distracted or a small jerk of the movement and the tissue tears. And then you stand nowhere. So the tissue is actually wasted. So it is I mean, a thing which is difficult. Then there are more chances of rebubbling. So first we create a bubble to place the tissue in place. But obviously there will be patients in which there will be some detachment. So you need to rebubble. So rebubbling rate is more in DMAC than DSAC for obvious reasons. Because DSAC tissue is more stabilized, it hardly detaches. Then more endothelial cell loss. And it's a challenge in aphakic patients because this is a thinner tissue. So the moment you inject, it goes straight into the vitreous cavity. So these are the indications. Just one word.
It's a challenge. Is it not a contraindication or a challenge?
Which one? Aphakic. It's a challenge. It's a challenge because people are doing it in aphakic patients as well. There are special strategies for that. Alright, so indications, nothing new. Any endothelial disease, you can do it. There is one thing that there shouldn't be any stromal scarring. So if you are having a scar in the stroma, this will not go with DMAC. So you have to have a normal stroma. By normal, I don't mean that absolutely healthy. It might be adivetous, but there shouldn't be any scar. But otherwise, any endothelial disease, and you can do DMAC. Now, sometimes when I ask my trainees that what is the difference in indications of DSAC and DMAC, so they say that as stroma is transplanted in DSAC, so if there is a stromal pathology as well, we'll do DSAC. But practically, DSAC or DMAC both have got almost a similar indications. There is no difference. DSAC has nothing to do with a stromal pathology. Alright, so this is tissue preparation. So we place the corneoscleral button. Now this is an intact corneoscleral button. Nothing has been done, no previous peeling or preparation. So we place it upside down, and these are two simple forceps. These are suture type forceps. So we stain, but please notice that a healthy endothelium will not take up stain as much. Now this is the Schwalbe's line. We can see a scalloped border and a blue ring. So this blue ring is actually tubercular meshwork. This is Schwalbe's line, and this is endothelium. Now what we are doing is that with the help of a simple lens dialer, again it's a simple Sinski's hook, we are doing scoring. So what we are doing is we are creating a fracture line at this point of Schwalbe's line, so that the desmoid membrane, it starts to detach. We can notice there are certain radial pattern here. Now this is staining. This is the area where endothelium has been previously damaged due to some manipulation. But otherwise, a healthy endothelium shouldn't stain much with Alright, so we can notice that the scoring is being done, and we are gently lifting off this desmoid membrane and endothelium from the rest of the stroma. Now we should be very careful not to create any fracture line, because if the tissue is fractured here, it will become a problem. Alright, so once it is done, we can hold the tissue either with one forceps or two, but I prefer two because it broadens the area of mechanical pull, so that the chances of tear are less. There are special forceps for this purpose as well, but when I was doing this surgery, we didn't have that available to us. So we just utilize these two forceps. we have to be very gentle in this movement because this is the time where most of the endothelial cells are being lost. So we do it sequentially all around, taking each quadrant separately and keeping a bit of the central portion still attached, because if we detach it completely at this time, then it will float. So we want it to be attached to the stoma for the time being. Alright, so instilling some water, and we can notice that there is a fold at the periphery. So we are unfolding, but in this case we were unable to unfold completely. So we tried again and we miserably failed. It actually wrinkled more. So this will tell you the behavior of the tissue. This is such a delicate tissue. Alright, so we had to do some mechanical ironing of the tissue like that. But I am just touching the periphery because this is the portion which is not going to be transplanted. It's only the central portion which is going to be transplanted. So we have not touched that area. Alright, sucking out all the water, giving it a bit of more stain.
So which
And
dye
then-
you are using?
I'm sorry?
Dye कौन सी सर इस्तेमाल कर रहे हैं?
Simple VN2. Now this is 7.75. So we have already measured on the patient and we are utilizing 7.75. So it's a gentle tapping. Don't be hard because otherwise it is going to cut the stoma. So it's a gentle tapping just to cut the desmoid membrane. And after that, lift it off and take out the peripheral film. So you can see how easily it is peeled off. And the central portion is having a disc of the endothelium along with desmoid membrane, and that will be taken separately. Now this is scuba technique in which we do it underwater to reduce the endothelial cell loss. Alright, now we can see this roll over here. Now it goes to vision blue for further staining. Now this portion, if you are interested, we can show, but otherwise we can move on to the patient. This is a video which is showing that how can you improvise the injector system as well.
You didn't mark it.
That thing. Actually, that was not shown, but we actually cut an arrow. So we don't use S marker because for S marker you'll have to punch the stroma and the stroma will be wasted. So we use arrow. We cut an arrow from that. Alright, so this is simple Alphonse cartridge and we are preparing it for injecting as an injection system for the DMAC. So this is simple IV set. You can see that this has been cut in a slanting pattern, and after that we'll insert it into this cartridge and do it firmly, because if there is a leakage from here, the tissue is so thin that sometimes this will surprise you and it will come out from this place. So it has to be a firm placement. And after that, attach a syringe at this end. इसको थोड़ा हल्का सा फॉरवर्ड भी कर सकते हैं 10 seconds. Alright, so the system has been made. Now we will load the system with fluid. Now one precaution that there shouldn't be any air bubble in the fluid, because air bubble will tease you during the surgery. So we have loaded the system and now it is all prepared for this roll to take in. So this is the endothelium, and we can observe that we are gently sucking in, and this is going to be loaded into this cartridge. Now at this moment, in this roll, this is a natural behavior of the tissue that the endothelium will be out. So we have to remember that. Whenever it rolls in this configuration that the endothelium is on the outer surface and the desmoid membrane that is on the inner side. So we have to remember that. Now it is loaded for the patient to be transplanted. Other video, next slide. Alright, so this is just a slide showing that the roll is formed, but we need to remember that the endothelium is on this side, and this is the desmoid membrane. Now, when we inject, we have to observe that which way it is injected into the eye. Because if it is like this and we unfold, the endothelium is on the upper side, so it will be actually the wrong way. So the right configuration is this. This is the right configuration, because now the endothelium is on the under surface, and if we unroll, the endothelium is going to be in the right position. Up next slide, uski video mein jara. Now again a similar patient, but a bit more aggressive disease. We can see that the visibility is very poor. Alright, The initial steps are absolutely the same. So removing the epithelium for improving the visibility, marking the area, side ports and main NCA. Now first side port, some air goes in and we'll do the descemetorrhexis in the similar pattern. Now please notice that the descemetorrhexis has to be slightly larger than the size of the transplant. It has to be slightly larger. So even if there is a gap between the two endothelial surfaces, it's permissible. But there shouldn't be any overlap between the two because this will be the area from where the detachment will start. So we can see the descemet membrane is peeling off very easily. Injecting some more air. No. That is a no-go area because there is a lot of temptation to do that. But given even an atom of the visco and this will...
People are doing it.
People are doing, but we have to be very meticulous to remove each and every part.
I do it as well.
Alright.
You can do it. You can do it with a visco.
Then you can do it. Alright.
You can do it with a visco and then take the visco out and then put the
you have to be
air.
very meticulous. वो जो मेरा सुपरवाइजर था वो कहता था कि बहुत तसल्ली हो गई कि निकल गई इसको फिर दोबारा अंदर
मेरा
फिर
सुपरवाइजर
निकाल
कहता था डाल दो फिर
ये सुपरवाइजर्स की लड़ाई होता है. Alright, this is a preloaded tissue. So this is a glass tube in which we got the tissue prepared and preloaded from America. Alright, so this is the tissue. Now you can see that we are going to inject it. Now this is a critical step because if you are not careful, the tissue will come out from this area, the place between the injector and the incident site. Alright, so the tissue went in. Now just close the main port. And now this is the tapping movement. So now the instruments in your hand are only water or air. You can't handle this tissue with instrumentation inside here. So what we are doing at the moment is that we are creating water waves to unroll the tissue. So this tapping, although it appears very simple, but this is a very technical step in which you have to be at the right place. Alright, so there is a little fold here. So I'm utilizing this air bubble to unfold the area. So you'll see that all the margins, they are unfolded with the help of this smaller air bubble. You can see that air bubble moves and it actually unrolls all the margins. Now an inferior 3i, just to prevent pupil block. And then some more air unfolding. Now look at the S. So this has to be a straight S. Now this is the milking movement I was talking about. So we do it for like a minute or two so that any fluid which is above the surface, it goes out. And then a BCI will apply and the surgery finishes. Again the patient lies flat. Next slide. हाँ बस अभी आप वो पोस्ट ऑप आ रहे हैं. Now, if you have got time, this is a live OCT assisted DMAC in which we are seeing the OCT image of the cornea. We can see it's quite thick and we can see that the endothelium is quite irregular. And now the descemetorrhexis, you can see the instruments and the endothelium being peeled off here. Yeah. So you can see that the endothelium, the patient's endothelium is coming off. This is the instrument. This was the shadow of the instrument. You can clearly see that the endothelium is off. Alright, so once it's removed, then we are going to make the main port. In this case, it was 3 millimeters. We can see this is the tissue lying there, so we have to pull it out. So the tissue is coming out. There was a little adhesion here. So usually we observe that the incision sites of original cataract surgery, at that site it's a bit difficult to pull the tissue out. There are adhesions. Alright, just stretching it over the surface to ensure that no part is left in. And after that the tissue will go in. So now here in the anterior chamber we'll be able to see Now, is it the right orientation? इसको यहीं पे रोक के रखिएगा. What is the opinion of the house? इसको यहाँ stop कीजिएगा, पीछे थोड़ा सा back हो. जी यहाँ पे. Is it the right orientation?
No.
No, yes. No. Because endothelium is supposed to be on the outer surface. So if we unroll like this, the endothelium is going to be squeezed between the desma and the stroma. And that is the wrong orientation. So this is the advantage of live OCT, that even if you don't have a marking, you can still make out which direction you are. But I mean, it's not a must. If you don't have, you can always do that. There are ways. आगे चलें. Alright, so we will unroll it in the similar fashion. Just trying to flip the tissue, and now probably it has been flipped, because now the orientation is right. You can see this orientation is good. Again, PI, it should be done before this step, so we forgot to do it. बस ठीक है, अभी आप इसकी एंड पे लेंगे, इसी वीडियो का एंड पे लेंगे, नहीं उसी वीडियो का एंड रिजल्ट देखेगा, बिल्कुल लास्ट. Alright, so we can inspect the tissue as well. So once it has been stretched, air has been injected, so we can inspect the tissue. Is it in the right place? Is there any overlapping? You can see the incision sites as well. The BCL, so BCL is this much thick, almost 200 micrometers. Next slide. So these are few of the post-op results. वो दिखाइए, नहीं वो आपने वही वीडियो
Operatively, the visibility was less if we do positive.
अच्छा, जब हम OCT करते हैं तो उसमें ये प्रॉब्लम होती है, बिकॉज उसका जो आई पीस है उसके अंदर भी हमें OCT इमेज नजर आ रहा होता है, so उसकी वजह से जो विजुअल क्वालिटी है वो थोड़ी सी रिड्यूस होती है. बट यू हैव गॉट द ऑप्शन इन योर फुट पैटर्न, सो आप उसको अपनी मर्जी के मुताबिक टर्न ऑन करते रहते हैं. सो जब आपको जरूरत होगी यू कैन टर्न इट ऑन, अदरवाइज यू कैन टर्न इट ऑफ. तो
Although it's very good to, confirm the orientation of the graft and the OCD, but if the things are clear and you see that it has been folded on the side and you know which surface it is, that means that when you are not doing this OCD, the visibility is lower and you can.
बिल्कुल सर, that's why we keep it actually off at the off position most of the time. So we turn it on only when it's needed. But there are obviously advantages that you can see the tissue, you can see any overlapping, you can examine your incisions and many more. आगे चलें. Next slide. So these are post-op results. We can see the clarity of the cornea, we can see the OCT very nicely attached, BCL is in place. Another patient, this is actually my first case when I came back to Pakistan, so this is the first case. And few more cases, still few more. So you can observe that this is probably first or second post-op day. Air bubble is still in, but we can look at the clarity of the cornea. So this will actually surprise you. This is no way matching the clarity of conventional PKP. Sir, thank you very much. Sir, so nice. I'm honored. Sir. Alright, but there are complications as well, that sometimes you will insert an inverted graft, endothelial cell loss, graft detachment, pupil glaucoma. I've encountered pupil glaucoma myself. So these things, they do happen. Then late failure is also there, because there is a lot of endothelial cell loss. So sometimes even if the tissue is not rejected, it gradually fails. Sir, thank you very much. Thank you.
Can I just add one thing? Because there are many new faces here, we haven't mentioned about the selection of the donor, because that's important when you're doing a DMAC. If you've got the choice, it's better to be non-diabetic and older patient. If you try the DMAC in a younger donor, that will be a nightmare, and the diabetics are a nightmare. So if you've got choice, like you've got 4 or 5 corneas, don't do the younger one, go for the older one. And don't do the diabetic one.
Pertinent point. Alright, so we are almost towards the end of our session. Now again, about the orientation, we have already discussed that. What is the opinion of the house? How is the orientation? Now this is real life. So we assume that probably it's not very difficult. We all are used to do microscopic surgery, but this is real life. So how will you guess? Is it folded like this, or is it folded like this?
To us it seems wrong.
This is wrong.
Yes.
You're absolutely right.
Thank you.
Yep, perfect. So this is actually wrong orientation. So we need to flip the tissue in this case. Again, there is a fold. So what is the opinion of the house? Is it folded upwards or downwards?
Upwards,
Upwards,
upper foot.
downwards, downwards. So this is what happens. You can't actually guess. Now again, two folds, one on this side, one on this side. What is the opinion? Right or wrong? Wrong. Is it wrong? Yeah, this is wrong because this is this way. So this is wrong. So this is what it is. This is right orientation, this way. So OCT actually helps you, but it's not a must. Even if you don't have an OCT. Now this is again the right orientation. You can always get away with that. All right. अब आखिरी एक वो है pseudo triple procedure. Are we supposed to finish at 3? Sir, but एक वीडियो सर इसमें बस दिखा देता हूँ, then we'll finish. क्वेश्चन आंसर हम साथ साथ भी कर सकते हैं अगर कोई इसको आगे लेके चलें, बस इसमें जो वीडियो है वो दिखा दें. हाँ, ये वाली वीडियो. So he was a case, and it usually happens because anybody who is having some endothelial problem like Fuchs endothelial dystrophy, their cataracts are very mature because nobody is actually attempted to do that. So I encountered a similar patient, Fuchs endothelial dystrophy with a mature cataract. All right. Now you can also see that the pupil is also very small. So all the problems, they actually come in groups. So not a single problem but multiple problems. Mature cataract, poor visibility, poorly dilating pupil. So we stained and then injected some gel obviously. And then try to do decimatorexis. So what we do is that we remove the epithelium and we remove the endothelium as well. So removing these two layers actually improves the visibility. Although still the thickness of the stroma is more, but the visibility improves. So this is almost the same step. In the similar way, you remove the desmoid membrane. But here you feel lucky because you can use viscoelastic for the timing because you have to do a phaco, so you can utilize visco as well. You can see that the membrane is being peeled off. The main port. You can see this is for phaco and this much size is for subsequent T side. So we are observing and then trying to do a phaco. Now trust me, it was a very difficult phaco idea because it was pronascent cataract and it gave me a tough time. At some stage during surgery, I thought that I've started the surgery, but probably a VR colleague is going to finish the surgery off. But thanks God, everything went well and the phaco was done.
You may fast forward the.
हाँ, इसको forward कर दीजिए थोड़ा सा phaco थोड़ा और forward करते जाए मैं आपको बताऊँगा. करते जाए थोड़ा सा. Alright, so once you have done that, then meticulous removal of the viscoelastic. Second thing is that whenever you are doing a triple procedure, then please select hydrophobic IOLs. Because we are going to inject air and raise the intraocular pressure to 60 millimeters, so sometimes there are cases in which hydrophilic lenses, they got opacified. So hydrophobic lens will be the choice. Secondly, keep the rexes a bit smaller because there will be a lot of turbulence in the eye. So keep the rexes smaller so that the lens doesn't move. So in this case, we are not making a new incision. We are actually utilizing the same side port to pull the tissue in. Thoda forward karte hain. Now we can see the tissue here. उसी तरह 10 seconds. We can see the S stamp as well. So the S is straight. That means we are in the right orientation. And now we inject an air bubble underneath. You can see. Now there is still some fluid between the two. So this is another advantage of the OCT that you can clearly visualize. So this is pre-op, and this is post-op. So you can see Beautiful. The patient was happy. So with this, I thank you all for patient listening. It's really difficult to tolerate one person for complete 1 hour. Thank you very much.
Thank you very much. This is an excellent presentation. I just want to talk about the preparation of the tissue using a femto laser cutting of the endothelium. Actually, how if you are if you
On kar.
Please hold the yaar. How much thickness of the endothelium and the descemet should you aim if you are cutting the endothelium and descements with the femto laser?
I think lesser the better, but you need to keep in mind that we shouldn't go full thickness. So beyond that, the lesser the better.
I just want to, a little bit demonstrate how to we cut this endothelium with femto.
Sir.
This is the corneal button ups and down, endothelium up.
Yep.
When you are doing this artificial chamber,
Yeah.
usually doing this the arterial malar graft, the epithelium is up. And we
Yeah.
used to remove maybe 400 or
Yeah.
450
We usually do that. Yeah.
stroma along the epithelium.
Yes.
But while we are doing this endothelium, we have to go endothelium up.
All right, sir.
So it can be
Actually, I have
done.
not
मैं
done.
आपको बता रहा हूँ.
मैंने इसमें नहीं किया,
I'm
sir.
telling the audience that it could be done and there is no harm to the endothelium while you are doing it the ups and down. You make the endothelium ups and down on the artificial chamber, and just to apprehend just like you are doing in other femto laser surgeries like
Right,
LASIK
sir.
or something, and you remove about maybe 30 micron or 35 micron of the endothelium and the descemet,
All
and
right.
your tissue will be prepared by whatever diameter you want, maybe 8 millimeter, 9 millimeter, or whatever.
Mm.
I just wanted to know your, advice that how much depth or thickness of the endo, because it is, you have to plan. I mean, it is not that you put and you give incision and you peel off,
Yeah.
and whatsoever the thickness in that patient is, it will come up with your preparation of the tissue.
Yeah.
But doing with the femto, you have to tell the machine that this much micron
Yeah,
you have
obviously,
to
that
cut.
is very precise.
And so what would be our aim?
Mm.
If we are doing it, it is a DSAC, you can have a little bit of stroma as well, but
Yeah.
then if you want to do a DMAC, we only want descements and endothelium. So making both of, how much thickness one should aim, in your opinion?
Sir, actually, I have not done this procedure specifically. I have done femto-DALS, but not femto-DMAC.
Yeah.
So I'm not very sure. But as Professor Mahfouz mentioned, that the total thickness of the endothelium and the descemet membrane in toto is like 20 to 30 micrometers.
Okay.
So if our machine is precise enough, and we are sure that we'll be able to lift this thin the flap from the rest of the tissue, then probably if I was doing, I would still aim for 50 or something, because I would like that.
50, it will become
It will become a DSAC.
DSAC.
But if we only trying to do DMAC and like we aim 30, then probably lifting off it from the surface and doing all that manipulation.
It will be cut by
maybe-
the femto.
Mm.
It will be not only the circular cut will be by the femto.
Yeah, the
but
interface cut will
deeper
also
cut
be
will be also femto. It will be
Yeah.
much easier to remove this flap. Just like all
LASIK flap,
of
right.
us know that
Yeah.
how easier it is to lift the flap of
LASIK
LASIK.
flap.
Yes.
While we are doing femto LASIK, that means it is very easy. You just lift up and put a separator, and it is reflected.
But it is 100
So-
micrometers.
But
That is
I mean working on a, वो हम कहते हैं ना कि removing the endothelium manually, it is just like walking over pulsrat.
Yes.
It is so
बिल्कुल ठीक
difficult. I mean, it is so difficult, but you are. I don't know how you can do it. I mean, you are doing it. It's very well. I mean, but most of us, we are really afraid of doing it. And whenever I do, I always do it. जैसे आप कह रहे थे कि radial cut हुआ नहीं तो गया नहीं.
Yeah.
And once you have applied an ununiform force, and you are going to tear it, so delicate
That is
tissue
very
is.
stressful. So
But I
that's-
think femto will be great help. You
Yep.
may save your retina if you start doing with the femto. Even it could be the other way around as well. If it is epithelium up,
Still we
and
can come
you
in.
can actually see the thickness of
Yeah.
all of the graft,
Yeah.
and then you then you can calculate
Yeah,
that
how
this
much?
much of the tissue
Yes.
should remain there, and you can cut it, the anterior part, and that anterior part that could be used for the anterior allograft, and the endothelium could be used for.
Yeah.
I have done few of the cases.
All right.
It is only for poor patients that my paid patient actually have to have a DAL, femtocystic DAL, then I saved the endothelium.
All right,
in the
and
same
use
tissue,
it
and
for-
I used it in the
Perfect.
in the-
Yeah. I think we should all do that. Yeah.
the idea. Thank you very much. This is
All right. Thank you very much. Sir,
It's really
please conclude.
pleasure to listen to your lecture and to learn many things, particularly looking at the videos. And we are all very grateful. Thank you very much.
Thank you very much.
Any questions from the audience? No? बड़ा मुश्किल काम कर रहे हैं ना. It appears to look at the videos, it appears that it's so simple.
Yes.
But while you are doing it, it is hell.
So why to use older patients for donors?
Yes. Now, because the thickness of the plasma membrane, it keeps on increasing throughout your age. So, lesser than 45, they've got thinner plasma membrane. So, chances of, as I was talking, the chances of some error, like a
When the
fracture or
tissue
anything, so it is high. So, the older patients, they've got slightly tougher tissue. But on the contrary, older patient would have some low endothelial count. So, जैसे सर ने कहा पुल से रात है ये वाक्य पुल से रात ना इधर के ना
He's talking about the ease of pulling the
Removing the
endothelial
tissue.
gaseous membrane. It becomes easier in elderly.
Okay.
You know, if you are doing a DALC surgery and you are not using femto, it's manual, you have to peel off the endothelium and we waste it. In younger corneas, it is not possible even to have a microsponge and you just try to peel the endothelium off. It is not possible. It is so strong. It's very strong adhesions in younger patients, and it is very difficult to. And in those, I just to add, if you want to use, there is an advantage of having young corneas, and if you can use it with the femto, you are having a much more population of endothelial cells in younger corneas if you can do it. We are selecting elderly cornea, and already there is about 2,000 or a little bit of 2,200 in good corneas. And if you are using young corneas, using femto preparation, you can have about 3,000 or 3,500 population of the endothelial cells. It is really, much more beneficial for the patients to have this, such a large population of
Sir,
endothelial cells
the
in
thickness of the
general.
endothelium is around 15. Gaseous membrane is around 10. So it turns out to 25. So
You can have
for
30
our
microns.
chances of mistake, if we keep one or two more, that's take 27. The machine will not damage a lot.
Obviously, it will not damage the endothelial cells. It may have a very 1 or 2 microns less of the desmids.
Yeah.
It doesn't matter. And you can have maybe 5 microns more than that. When you aim for the 30 microns, and there are very less chances of having the damage to the endothelial cells.
30
And it is
will
already
include,
find it is already cut. You are
30
not
will
going
include
to.
some stromal tissue.
It is 5 micron stromal tissue. It's just like that.
Yes, that's fine.
This is an idea. Those who have got a femto laser, it will become much easier, and your life will become so comfortable.
Comfortable.
Thank you very much.
Thank you.